We welcome Dr. Sadaf, who's the head of the Department of Surgical Gastroenterology at Srinagar Institute of Medical Sciences, Srinagar, and Dr. Ragini, who's an associate professor at ILBS, the Department of Hepatopancreatic and Biliary Surgery. Welcome, our moderators.
Thank you.
Over to you.
Thank you. So, ma'am, with your permission, I can introduce the speaker.
Yeah, please go ahead, Ragini.
So, Dr. Gopika, she's our first semester MCH resident who's just joined us in June. And she'll be presenting the journal club today on the PRICE-2 trial, which has been published in Lancet Gastroenterology and Hepatology. Gopika, please take over.
Thank you, ma'am. So good evening, everyone. I'm Dr. Gopika. Today, I'll be presenting the journal club on PRICE-2 trial, a multi-center randomized control trial evaluating hypovolemic phlebotomy in liver resection. The title signals both the intervention, the hypovolemic phlebotomy, and the high-risk surgical context in which it was tested. So this trial is notably as the largest and most definitive study yet to evaluate this strategy. Now, the Lancet Gastroenterology and Hepatology is a leading global journal in this field. It has an impact factor of health, clinical, and public health knowledge. Its high ranking further underscores the credibility, visibility, and significance of the PRICE-2 findings, and I chose this journal. Liver resection remains one of the most technically demanding procedure in HPB surgery and one of the most major challenges that we face is blood loss. Reported ranges from 12 to 34%. Excessive blood loss not only worsens the surgical visibility and threatens oncological margins, but also directly worsens the outcome. Transfusion in itself is not benign. This makes it clear we urgently need strategies to minimize transfusion during hepatectomy, and that's exactly with a novel approach designed to reduce blood loss during liver resection. The principle is simple. Whole blood is withdrawn in a controlled manner at the start of the procedure, inducing a transient state similar to class 1 hemorrhage. Importantly, unlike normovolemic hemodilution, no volume replacement is given. This results in a lower central venous pressure and reduced venous bag. Once the resection is completed, all of the collected blood is reinfused back to the patient before the end of the surgery. Many observational studies have suggested that this technique can reduce blood loss and transfusion before the PRICE-2 trial. Now, PRICE-2 trial was designed to test a simple but important hypothesis that hypovolemic phlebotomy could significantly reduce the need for perioperative red blood cell transfusions in patients undergoing liver resection. Primary aim was to evaluate whether this strategy comparing with the standard care lowers transfusion requirements within 30 days of surgery without adding any risk. The interval phlebotomy, in which 7 to 10 ml per kg of whole blood was withdrawn after induction, but before the liver transection. Importantly, the removed blood volume was not replaced with IV fluids. Instead, anesthesiologists managed the hemodynamic stability with the valve pressures to maintain the desired low volume state. This approach aimed to reduce central venous pressure and improve the surgical field condition. The control group, on the other hand, received the usual care, careful fluid restrictions, target tranexamic acid. Timing and method of phlebotomy were left to the anesthesiologist's discretion, allowing real-world adaptability across centers. This shows how they approach the transfusion governance and bleeding risk in hepatic intraoperative transfusion, ensuring decisions are evidence-based rather than arbitrary. Post-operatively, they adhere to the AAB guidelines, transfusing only when the hemoglobin is less than 7 grams per deciliter or if the patient is symptomatic. Final decisions with the treating team with preoperative anemia optimized under blood management program. It's a simple bleeding risk score ranging from 0 to 3. 1 point is added for each preoperative anemia, presence of primary liver malignancy such as HCC or biliary tumor, and for major resections. The higher the score, the greater the vigilance required. Together, these measures ensure avoiding unnecessary transfusions while maintaining a patient safety. The trial was multi-center study conducted across 4 Canadian tertiary care centers. Trial was truly multidisciplinary in its design and execution, involving surgeons, anesthesiologists, transfusion medicine specialists, bank technologists. This ensured that both surgical and transfusion practices were standardized and rigorously monitored across. Out of 1,565 patients assessed for eligibility, 486 were randomized. The randomization was performed using permuted blocks of variable length stratified by center. Were assigned to the hypovolemic 41 to the usual care. In both the groups, some patients did not proceed to the liver resection and continued the allocation intervention. Ultimately, 223 patients in each arm were included in the primary analysis. Regarding patients and surgeons and outcome assessors were kept blinded to the to actively deliver the phlebotomy. This photograph on the right demonstrates how the operating field was draped to maintain the surgeons involving 3 or more segments, central or posterior resections, cirrhotic patients undergoing segmental resection, and exclusions included significant comorbidities like anemia under HB of 10 grams per deciliter, thrombocytopenia, renal dysfunction, major cardiovascular or vascular disease, active infection, and pregnancy. Importantly, patients refusing blood transfusions were also excluded. Primary endpoint was the need for at least 1 unit of RBC, meaningful and objective measure directly tied to the central problem of perioperative bleeding. Secondary outcomes captured broader measures like intraoperations graded using classifications and mortality. This study also assessed surgeons' perception of operative field quality, an innovative measure that links physiological changes to the surgical ergonomics. Safety was a key. Ischemic complications, bile leaks, and mortality up to 90 days were closely. This ensured that any benefits in transfusion reduction did not come at the cost of harm. For the statistical analysis, they powered the study to down to 10% with 80% power and 5% alpha. After adjusting for expected non-compliance, they landed evenly across the two arms. Modified intention to treat principle was used. Only section because the tumor turned out to be unresectable were excluded. That's because the randomization could not affect the resectability. Everyone else, including the crossovers and protocol deviations, stayed in their original group. Now, the primary analysis, the main outcome was transfusion within 30 days. They reported the risk ratio with well. For the secondary outcomes, complications and binary outcomes, they use the same approach. For continuous outcomes like blood loss, they use linear regression parametric methods like Wilcoxon's if the data were normally distributed. So overall, the analysis plan was very rigorous, powered properly and fully adjusted and transparent. This is the this table shows the baseline characteristics of patients in the two arms. As we can see, the groups were very well balanced. The mean age was around 61 in both, with similar distribution of sex and body mass index and ASA. Charlson's comorbidity index was also comparable with the two arms with a median of 7. Preoperative KPUs were also same, 37% phlebotomy and 43% in usual care. Overall, the similarity across these key baseline parameters suggests that the randomization was successful and any difference in outcomes can be due to the intervention rather than the baseline characteristics. The trial found that the hydration rates in half, only 8% of patients required a red cell transfusion compared with 16% in the usual care group. This translates to a number needed to treat of just 11, and which is impressive clinical impact. Lower in the phlebotomy group, and importantly, surgeons reported better operative conditions. refilling, and easier transactions. On safety, there was no increase in major complications or mortality. A higher rate of grade A bile leaks were observed, but they were not clinically significant and typically resolved quickly. Overall intervention proved both effective and as well as safe. This is a forest plot which shows the primary outcome. As said, the overall transfusion significantly was lower in the hypovolemic phlebotomy group, 8%, which is compared to the 16% with this usual care. And the risk ratio is 0.47 with a confidence interval and just not crossing 1. Subgroup analysis, if we see, for example, if we take preoperative anemia also, the hypovolemic phlebotomy arm shows a lesser chances of blood transfusion when compared to the usual care. The findings of PRICE-2 suggest that hypovolemic phlebotomy is a powerful yet simple intervention for blood conservation in liver resection. It achieved a clinically meaningful reduction in transfusions and improved no increase in serious complication or death. Signal for increased bile, grade A bile leak appears trivial as these leaks are not clinically significant and typically resolved before discharge. Still, several limitations are present in the interpretation, raising the potential for bias in transfusion decision, likely diluting the observed effect. Lastly, transfusion rates were already. PRICE-2 provides the most compelling evidence yet that hypovolemic phlebotomy can and should become a routine practice. This trial firmly established that it is both safe as well as effective. It significantly cuts down allogenic transfusion needs without adding complication. This makes it especially appealing for high-risk resections. It is a very rigorously conducted trial, randomized, blinded study with strict protocols. Design gives result and reassures that fluke of bias. The immediate perioperative benefit is clear, but we don't yet know about long-term consequences, which is like oncological outcomes, recurrence rates, or even quality of life. Future research must be done to plug this hole. This technique shouldn't there can be a real opportunity to test it in other complex operations like transplant or HPB oncology, or even in non-HPB fields where there is high risk of bleeding. And in conclusion, hypovolemic phlebotomy significantly reduces perioperative conditions without increasing complication. Thus, it can be a strategy for perioperative blood management. Even though the trial has multiple strengths that gives weight to its findings. First, it is trial of hypovolemic phlebotomy. It has 486 patients across 4 major Canadian centers. Size and scope gives it statistical power and credibility. Second, the trial employed rigorous blinding. Surgeons, patients, outcome assessors all were unaware of the allocation. Allocation concealment was very generated. Finally, the study design reflects a real-world practice. Multiple surgeon anesthesiologists across 4 centers implemented the intervention successfully, making the findings widely applicable and not dependent on a single center. Even after having all these strengths, study, like first, most important is anesthesiology, of which they can influence transfusion decision intraoperatively. Post-operative outcomes support the validity of the result. Another limitation is protocol deviation. About 14% of cases in the phlebotomy still represent challenges in execution. Finally, transfusion rates in the control arm were relatively norms of high transfusion rate. This may reflect a high surgical expertise and strict transfusion criteria in Canadian centers. In other contexts, the absolute benefit might be even greater, but it also earlier work was suggestive, but it was very limited. Many observational series and meta-analysis had added weight, showing reduced bleeding and transfusion without adding morbidity, but it remained at the risk of bias. Janagin trial of acute normovolemic hemodilution showed reduced transfusion, but the intervention was cumbersome, requiring liters of blood withdrawn and IV replacement fluids. One trial which demonstrated feasibility, but it was too small to confirm efficacy. And then we had the PRICE-2 change, which changed the game. With nearly 500 randomization and clear positive results, it provided a definite ready for clinical adoption. This is the 2000 study which showed that allogenic transfusion rates were high, but it was a very early study and single center. It was safe and effective in cutting mammogram-based tailoring. Then we had, this is the PRICE-1 trial, which was underpowered and not designed for efficacy, but it did confirm the feasibility and it justified the multicenter RCT. So the bottom line that we can draw is intraoperative hypovolemic phlebotomy should be done in high-risk liver resection surgeries, which can be a practice changing. Thank you.
Thank you, Gopika. That was an excellent presentation, especially given the time constraints that a first-year resident faces. So now I'll first invite Dr. Sadaf for her comments before opening the discussion to everybody.
Very interesting paper, and which might mark some more occurrence of at least, if not a larger trial, but studies widespread all over the world in for taking care of requirement of transfusions, which becomes a complex circle if you lose more blood during surgery. But I thought that one baseline parameters were comparable. The control arm should have had some basic norms, or it should have been planned what was permitted and what was not permitted, because it was left to the discretion of the operating surgeon about all intraoperative measures, somebody using sprinkle, somebody not using, somebody using total exclusion, both inflow, outflow. Okay. Then the gadgets available, like the QSA availability, non-availability, those might be a little, though the strength and the statistics of the study, those might be some important factors where the further studies should take into consideration these things. Having said that, it was very well presented by the doctor, and you guys made a very good selection. It's a very important thing that we have a control of the amount of blood loss, because all surgeries, liver resection, pancreatic duodenectomy, donor resections, the outcomes are quite linked to the amount of blood loss. The lesser the blood loss you have, the better results you have. All recovery parameters are better. So that is what I would like to add. And I would also like to say that in the basic parameters, what they said that the two arms were comparable. Did he make a mention about how many laparoscopic and how many open liver resections were included?
I think about 9
No, ma'am,
or
not specific.
10% are laparoscopic and the rest are all open liver sections.
In either group, they were comparable, laparoscopic was,
Yeah.
because laparoscopic has a little advantage of lesser blood loss due to the
automatic.
ergonomics.
Yeah, but it was
greater.
equitably distributed.
Okay, good. So anybody in who wants to chip in, Gayatri, others?
I just like to add one thing. Basic premise is that if you're going to do a hypovolemic phlebotomy, it is going to work by dropping the CVP. That's what the older studies,
Exactly.
the observational
It's
studies
quite a
have shown us.
proved thing in older studies. You are dropping the CVP.
So the second thing is, if the CVP was dropped, then is why both the arms seem to have an equitable drop in the CVP. And if they have the same drop, then why is the loss different? Or is it that the hypovolaemic phlebotomy arm did actually have a greater drop, because that particular difference of the CVP is not something that they have mentioned. The second interesting aspect is that if you look at the volume of blood that is lost in the hypovolemic arm, it's about, I think, 679 odd ml. And in the control arm, your usual care arm, it's your 800 ml. So it is not statistically significant. But even if it were, it's clinically also insignificant to have a difference of about 120 ml, 120 ml of difference. And actually, if you look at it, the hypovolemic phlebotomy arm on an average would have lost 500 ml more because of the blood that is phlebotomized for autotransfusion. So they, during the transaction period, would have a loss of 500 plus the 629, which is close to 1100 ml, versus 800 ml, which is in the control arm. So were these patients on higher inotropes compared to the control arm? Was these higher inotropic requirements responsible for the ischemia of the bile duct and higher amount of bile leaks in this arm? So we need to know the physiological changes that took place, the inotropes requirement, and despite technically having a higher volume of blood loss during the transaction, when was the blood transfusion done? Because technically auto transfusion, but nevertheless all the patients in the hypovolemic arm have received one transfusion at least. So what was the duration of this? What was the time point at which this blood got transfused? Does that have an effect? So these are some things that I feel we should know in greater detail, which the authors have not given us any information on in their study, which could have some bearing on how we understand how this hypovolemic phlebotomy has, other than the CVP, how has it actually led to a reduced transfusion rate.
So it actually looks like that it was an alternative to reduce CVP.
Yeah, but then if you look at the distribution of the less than 5 millimeter CVP and more than 5 millimeter CVP, there isn't much of a difference.
Exactly.
And in fact, if you look, 55 patients had less than 5 millimeter CVP and 39 had less than 5 in the hypovolemic arm, 59 in the control arm. This may not be statistically significant, but whatever is it, it is more in the control arm. More people have lesser CVP in the control arm compared to the hypovolemic arm. So this is something very interesting, that how do you explain all this
Yeah.
data?
So you made a point very well that the requirement of vasoconstrictors to maintain the hemodynamics without volume might be important to be noted and given in details about in the two arms. That was exactly what you wanted to convey, because not only they picked up a bile duct injury leaks to be higher, but then other complications might also occur due to excessive use of vasoconstrictions, like the comorbidity with cardiac patients may increase, and there are many more things to it. So if we would go into details of all these things, we might find out some deviation from what they have put forward. But having said that, it has some added advantages also. The phlebotomy blood is the one which, on requirement, it must be to the discretion of the anesthetist then, and the clinical situation in OT. Maybe it might be required even after and around the procedure, where they prefer to use the. So that is somewhere like the concept of cell savers. So those added advantages are there, that you have your own blood and then it can be used for resuscitation or as per requirement. And yeah, to say that this was the only reason, there are so many confounding things which could have been explained in a better way. Anybody else who would like to make any
Dr. Gopi is,
Hi.
yeah,
Gopi is
yeah.
raising hand.
Hi, all of you. And
Hi.
Shravanti, well done. Good job with, not Shravanti, Gopika. Good job with the presentation. So, I randomization, all of that. But going back to the point that all of you mentioned, this hypovolemia, was it essentially only for CVP management, or was it more than that? So what I found in the exclusion is they have removed a lot of patients where this hypovolemia insult would. So they've excluded cardiac patients with cardiac illness, patients with a GFR which is less than, I think, 60, those with peripheral vascular disease. I mean, so many exclusions in order to accommodate this hypovolemia. So that in real world situation may restrict the number of patients to whom we can put this through. And another point is they've not mentioned about the amount of inotrope requirement. I'm not sure if I saw a lactate intro-op to tell us what the end organ damage was from even from the tissue damage. So I'm not sure I saw that bit of it. Has there been, Gopika, has there been any mention comparing this to or hypovolemic, situation, sorry, normovolemic situations? I didn't see any mention about that. I think that would be something that it would add to the value of this paper.
Yes, exactly.
Was there any mention, Gopika, because I didn't read like the entire thing. Was there any mention talking about this versus, autologous transfusion?
So all these patients did get the whatever the blood was phlebotomized and removed. At the end of the procedure, all the patients, irrespective of their requirement, had the blood transfused back into them.
Yeah, but I'm talking about, so this was done at surgery. I mean, I remember you mentioned whether the blood loss was, before transection. So they clearly mentioned that the bleeding happened before transection started. But what about patients where we normally, if their hemoglobin is good, we kind of, do an autologous blood, storing it and giving it to them
No,
if that's
no. So those patients were excluded. They have not done a pre-operative this thing, because anyway you cannot
they've
easily.
not done in this, but is there a mention of, the
No.
outcome discussion between the two?
No. That part has not been covered. So, like I was telling, they have not talked about the inotropes and they have not talked about lactates and the time for clearance. Those are the things they have not
Yeah.
brought into the discussion.
I
And
think if hypo,
And
if
I think if I've got it right, Ragini, then they actually they transfused it back. But see, if you're operating for 8 hours, 10 hours, in the middle of fourth hour, if there's a need of blood transfusion, they must have used it. No, if I got it
exactly.
right,
So
they
that's
have
what I'm
used it.
saying. So those details are missing as to what percentage of patients required blood before the transaction could be completed, because that is all going to have an effect on the CVP and how much. I mean, before we say that something works, we should also know how it works. So till now, the understanding is that it works through CVP, but then they have gone ahead and shown us, not given us details, but from what we can make out, the CVP doesn't seem to be the major operating factor here. And then for somebody who had an 800 ml of blood loss, vis-a-vis somebody who had a 679 ml of blood loss, the transfusion requirements are drastically different, and that's also a slightly bitter pill to swallow. Okay, I mean, how do you explain so much of blood transfusion differences when the volumes lost are not significantly different? And you roughly translate 500 ml of blood into 1 gram of hemoglobin drop. These are patients who started out with a hemoglobin of 13. So these are things that I am not still able to explain from this paper. And so in my personal opinion, before we can explain all this, it's a bit too early to incorporate this into our routine practice. The other thing is also about surgeons, the subjective experience of surgeons feeling that this is very easy and this transaction was bloodless. So easy transaction, I think they could have given us the liver transaction times, which would have made it a little more objective, that obviously when it's bleeding less and you're having to waste less time on hemostasis, your transaction is going to proceed faster. Because at least as far as
Yeah,
the bile
you
leak is
made a very
concerned,
valid point over here. Yeah, that's
and
very
as far as
important.
the bile leak is concerned, I think the bile leak goes against the easy transaction part, because one of the advantages of having a lower blood loss is that you're going to have a cleaner field. You can, look at your bile, just small ductules easily. You will have better hemostasis and biliostasis, but then you end up with a higher bile leak in the post-operative period in the lower blood loss arm. So those also don't seem to be really fitting in. Anybody else wants to make a comment?
I'm unable to listen to. I'm getting disconnected. So
There was one more thing.
I
Yes,
would
ma'am.
like to add one thing is that whether the authors actually believe that those units which they salvaged and used for keeping the CVP low and was retransfused the patient was actually the winning point in the scenario that ultimately they required less number of transfusions as compared to the other arm. So that can be taken as an advantage, but that can be taken as an advantage in the concept of blood saving and blood transfusion, because the paper overall seems to be more focused on the hemoglobin drop and the number of blood transfusions required. So the primary endpoints, they've kept it very simple as compared to making it a more there's so much of complexity to the liver resection which they have not considered. As all of you made a point or the other that they did not discuss about the operative time. If the surgery was better, easier, then the operative time has to be indirectly less. And of course, the mortality and the morbidity seems to be.
The other thing
Well,
is that,
interestingly, they have not reported any mortality, 90-day mortality in both the groups.
yeah,
And they mentioned about that also. Probably they chose the best of patients where, they've excluded a lot of the high risk patients in terms of the overall high risk, not so much from the surgical high risk alone.
no, I completely agree with you. But you know what is the most important? It was a very funny thing. I saw in the supplementary data that around 3 patients in each arm had myocardial infarction in the first 30 days or whatever in the post-operative period. So
Oh,
much
that's
so for
interesting.
their screening. I don't know for their screening, but still 0% mortality. Uh,
Mhm.
there are some things, and the other thing is that especially if we talk about our setup, even hypovolemic phlebotomy doesn't come without its cost, without its resources, and then maintenance of sterility and asepsis when you transfuse this blood back into the patients. So it's an added resource intensive thing. I mean, it's not as that you just put in these blood collection bags, you take it and then you store it and then you come bring it back and you transfuse it. So there are, every time when you transfuse something, starting right from an IV fluid to the bloods, everything that is invasive is going to have its own risk of introducing infection. So the phlebotomy, the act of phlebotomy as well as that of retransfusion comes associated with some risk which cannot be negated altogether. And the cost of the everything, and in our setting, we should really look into what is the cost of the blood transfusion vis-a-vis the cost of these phlebotomy, storage and retransfusion in our setup. Because I think in the US setup they have they have quoted close to $800 with the cost of their blood transfusion. So it may not be such in our country. So
And I would also like to know that I don't think she showed that what were the details of resections like in either group. They said that they were comparable indications of resection, like cirrhotics who underwent resection for an SCC, and the other causes like some resections are inherently very difficult and tend to have more blood loss, and the others are not, like how many liver metastasis. I think she gave a brief that they were comparable in either arm. But we don't know the details of it. She could have elaborated a little bit more.
yeah, I agree. I think that was part of the supplementary data, which she probably did not show.
Hmm.
But it's there in the supplementary data, and I think the proportion of major hepatectomies and segmentectomies are both comparable. About 80% were the major hepatectomies, and they're comparable in both the arms.
So we would like to take at least from senior liver surgeons that how feasible it is in our setup to think about such things. And one good thing about such trials is, or even if they are studies also, is that you involve more people. Like it is multidisciplinary involvement. Your anesthetist would feel more involved, and your blood providers at the blood bank people would feel more involved in such kind of studies. So can it would be feasible in centers like where people are doing liver transplant and are into more liver surgeries like your ILBS center. But maybe it might not be feasible at many centers where people are still doing a good amount of or fair amount of liver resections as well.
So
So
I think
and
the
but
way out usually in these scenarios is to go for multi-center trials, because liver resections inherently are if you exclude the donor hepatectomies, if you look at the diseased livers where you're talking about HCCs, so India, we don't have that huge volumes of colorectal. Most of their resections were actually for colorectal liver mets only. So we don't have that high numbers. Our major resections are actually biliary malignancies. So you got hyalocholangio, CAGBs, and HCC also. Those are our usual bread and butter. But so I think even then, for to reach a sample size of about 400 cases, it's easier. Even this is a multi-center study, so multi-center studies are the way to go if we want to reach larger volumes in reasonably shorter periods of time. No single center will be able to attain 400 cases of surgeries for HCC or biliary malignancies.
that's this
And
actually
then we also need to take our
should be
anesthetists on board.
multi.
I don't know how many of our anesthetists would be comfortable with the idea of bleeding the patient at the start of the surgery and working with hypovolemia. So,
They you really need to get them on board, and but then if they are involved and in tertiary healthcare and bigger centers, maybe it's a viable option as well. And then one more important thing is that to add to volume of resection, here in our state we have a lot of alveolar hydrated coming in. So
yeah.
I said that some of the resections are not on just a tumor in between and lot of healthy liver around. So they have a lot of intense inflammatory reaction around, and accordingly the dissection and the resection becomes more difficult. And as I said earlier, that such comparison should have strict control arm also. You should have some minimum defined control arm, like all of them had Pringle in either group, or all of them did not have, or selective site of resection. And nowadays we don't believe in making it you keep an excess for total exclusion, but you don't do it onto the hepatic.
Yeah,
So how
even the
many
liver
of them are still
transection
good?
techniques are not standardized. Even the technique of transection is not standardized. Some they are using energy source, some they are using Kelly crush is also used in some patients in this study, in a reasonable number of patients actually.
So how do you do it in your center? We CVP less than 5 usually.
Most of it is fluid restriction along with
Good.
vasopressors.
That's what everybody is doing. It our anesthetists are also providing similar standard of care.
Hmm.
And we give intermittent sprinkle for resection. And all of us do it
Yeah.
unless you're doing a smaller or a minor resection and like an extended radical cholecystectomy.
Yeah, but the Pringle, we don't routinely use Pringle, but yeah, if it's bleeding, then obviously that's one of the fallbacks things that is. So you do take your HDL control before starting off with the transaction,
Yeah,
but
based on
we
requirement.
don't use it as a routine till we feel it's becoming a little more bloody than usual.
So I would like to have comments from the presenter, that what is her learning from the paper.
What I got the thing that I took from the study is that it is a valid point about liver resections and bleeding. That is a main bigger issue that we come across doing while having liver resections, because here also in our unit, much of morbidity post surgery is because of the intraoperative bleeding. So I thought that would be a valid point. Second is they came up with this technique of hypovolemic phlebotomy, and focus too much on the good side of um, the trial, that I felt maybe the negative points were much what do you say not properly met talked about, like especially the cases that we take, it is never complete complete. So most of the patients that we get will be cirrhotic patients, and will be having higher risk of bleeding, but that they had kept it in exclusion criteria. So these things had created a confusion, doubt in my mind. But then I wanted the platform to discuss those queries, so that I get an insight into it.
But the intention of usually of superior trial is that from whatever pilot they had done prior studies, smaller studies, they had gone it with the concept of making it at a larger base. Phase 3 means they had involved at least 500 or more patients. And now, they had actually thought, the concept was that it was a superior trial. So they were expecting that proved also with a statistically significant number of difference in requirement of transfusions. 8 versus 60, you said. So that is almost half the number of the control group required transfusion. So that way it's good, but some gray areas are there. So you thought about the applicability to your center, and you wanted to know about the details of how you can critically analyze and what all, as you use the word negative and positives of the study, you can say that they were the achievements and the uh, gray areas where the detailed elaborative this thing is not there. Explanations are not there. That why did they excluded so many?
Those patients who fulfill the inclusion criteria of that RCT and not outside that. So the more restrictive your inclusion criteria, even though your study may be excellently methodologically robust, very good, significant results, but still it then becomes applicable only to a very small subset of those patients who are fulfilling its inclusion criteria. So if you look at the sort of patients who would undergo a hepatectomy here in our setup, a lot of them may not fulfill these inclusion criteria itself. So that would be the first issue. So you also need to know whether outside this, if you apply, so then the problem is that ethically speaking, you can't bleed a patient who's got an HB of 10 or under. You can't subject a patient to anemia if they already have some underlying CAD. So
And
there are those obvious
patients and all, you cannot take them into that group. Yeah.
exactly. So those issues are there, and so the obvious point is that this is something that will help a subset of patients, and maybe at least in those subset of patients we should use these techniques to help them. It cannot be, you cannot help everybody, but at least these sort of patients you can help, those who fulfill the inclusion criteria of this particular study.
And there is probably a way of blinding the anesthetist also in the study to make it, a complete this thing acceptable. But there should be because it must have been a labeled kind of a patient subjected to either of the arm. So if it should have been known to the person from the blood bank whether the phlebotomy is done or not done. But I don't know whether it can be is that blinding all that it stays all that. And then the anesthetist should come in and he should take his discretion. She should be also blinded at whether the phlebotomy was done or it was not done. But that is probably not possible because of, and they could have transfused those two units subsequently. I don't know the methodology modifications I'm thinking about.
It just makes it's possible, I feel, but the thing is that the more blinding you do, the more resource intensive it becomes. So you got to have one additional person who is not the anesthetist in charge of the case, who is not the part of the surgical team, to come bleed the patient, label the blood, and inform the blood bank that in case there is a blood requirement, this is the first blood that should be sent off for this particular patient. So then who checks the blood? So when you check the blood, when you want to match it, then obviously this blood would have the name. So there's a lot of those things. How do you make it? How it becomes much more resource intensive than it is at this point in time. Even now, I feel it is quite resource intensive for it to be applied in general to all the setups.
Exactly. So we have, the number of people who are around are becoming lesser, and we are done with our time duration. So we started a little early because this was our first meeting. So do we conclude it by saying that this our MCH lady, she made a very nice presentation today, and all cheers for the effort she has put in and given the details, and there was a lot of learning to all of us and a lot of critical analysis also. And this can be tried with the guarded uh, 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 approach based on feasibility of the particular center, and we can further document it as an not as a practice but as a study purpose or academic purpose, that how feasible it is and how helpful it is. Having said that, if anybody else want to say something, I think we should close the session. Shravanti and all of you over there. Gomti has left.
Yes, ma'am. I
Yes,
think
ma'am.
she had to leave.
Has left.
Ragini, should we close it now?
Yes, ma'am.
Anything more?
Yes, ma'am. I think we can close it.
Okay.
So thank everybody.
Thank you.
Thank
Congratulations,
you.
Ragini, for your first this thing. You really helped it out to give a kickstart. Thank you very much, all of you.
Thank you,
Bye.
ma'am. Bye.
Bye.
Good night.
Good night.